Hello and good evening, friends. Today is the second talk in the master series of the ACNS webinars. And we are pleased to have with us today a very eminent neurosurgeon who specializes in the field of neuroendoscopy. Ladies and gentlemen, may I have the honor to introduce you to Professor Luigi Maria Cavallo from the Department of Neurosurgery, Università degli Studi di Napoli, Federico II, Italy. Professor Cavallo has performed more than 1,500 endoscopic endonasal transfemoral surgeries for pituitary and more than 500 endoscopic endonasal surgeries for various other intracranial lesions, which includes craniopharyngioma, meningiomas, and clavicle chordomas. Apart from being a very skilled endoscopic surgeon, he is also a very keen researcher and has contributed to many publications in the range of more than 200, which have been published in many peer-reviewed international journals. And he has contributed to more than 32 chapters in various renowned textbooks. He is a regular speaker at various conferences around the world, and he has been invited to more than 80 international courses and meetings. Professor Cavallo is going to talk about an extended endoscopic endonasal approaches for craniopharyngiomas and pituitary adenomas today. To chair this webinar, we have a very senior renowned neurosurgeon who also specializes in neuroendoscopy. I am honored to introduce you to Professor Chandrasekhar Pujari, who is the professor and head of department, Bombay Hospitals, Mumbai, India. Professor Pujari is also the chairman of WFNS Neuroendoscopy and Neuroendocrine Committee. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I welcome the speaker, Professor Cavallo, and the chairperson, Professor Chandrasekhar Pujari, to this online platform of ACNS webinars. Dr. Liu Bunseng from Malaysia is my co-host for today. And with that introduction, may I please hand over the online platform to Professor Pujari, sir.
Thanks, Dr. Raja. It's an absolute pleasure to participate in this meeting, and I appreciate the job given to me for chairing the session today. And it's a real pleasure. You have already introduced Associate Professor Cavallo at Federico, with whom I have had chances to work with on a few workshops, and it's been a great kind of association with their department, in the sense that we have learned quite a few things. They have several contributions, original contributions to facilitate the endoscopic transperinodal surgery, some of which have actually changed our ways as to how we remove the tumors, how we take care of the CSF leaks, and even in instrumentation. So without much further ado, I would request Professor Cavallo to talk to us, take us through the need for endoscopic extended approaches for pituitary tumors, and then also talk to us about craniopharyngiomas in adults as well as children, I think. Thank you, and please, you can start, Professor Cavallo.
Before to start, I really would like to thank you once again for this opportunity. It's also an opportunity to see all the new friends. It's the only way we have now to meet each other. And in the next 30, 40 minutes, I will try to share with you the experience of our group, which is guided in Naples by Professor Cappabianca, concerning the endoscopic endonasal approach for craniopharyngiomas and pituitary adenomas. Okay, I will start speaking on craniopharyngiomas. I like this slide because you can see here one of the pioneers of the neurosurgery. It's Harvey Cushing, who since the beginning of the history of neurosurgery in 1932, defined craniopharyngioma as one of the most forbidding of the intracranial tumor. And he was absolutely right, because if you look the option we have beside the surgical removal, you can understand that maybe surgery is not the only answer to this disease. And historically, two different kind of approach have been proposed to remove this tumor. On one side, transsphenoidal approach, but on the other side, transcranial approach through different corridors or routes. But since the beginning was quite clear that the transsphenoidal route was deserved just for a limited portion of craniopharyngioma. I mean, those growing below the level of the diaphragma cell without involvement of the subarachnoidal space. And so just infra-diaphragmatic craniopharyngioma were amenable to the transsphenoidal route, and preferably the cystic one. And since the 60s, over the year, different variation of the transsphenoidal route have been proposed, from the classical transrhinoseptal to the sublabial to the direct endonasal macrosurgical approach, up to the more recent endoscopic endonasal approach. And this is the typical appearance of infra-diaphragmatic craniopharyngioma when you approach with a transsphenoidal approach, in this case with an endoscopic transsphenoidal approach. They really seems to be like a pituitary adenoma, are quite easy to remove. They can be solid, cystic, mixed, inconsistent, but the good things when you approach this tumor from below is that you are always protected by the diaphragma cell. So even if you have quite a large infra-diaphragmatic craniopharyngioma, you can really navigate inside the cell in all the recess behind or to the medial wall of the cavernous sinus, and you can quite easily remove this kind of tumor. And these are the typical infra-diaphragmatic craniopharyngioma. You see they really appears like a pituitary tumor. And quite often this tumor have a cystic component, like in this case, you see, and in sagittal projection, and they really are quite easy removed. And the good things is that in this kind of craniopharyngioma, you can also preserve at least some part of the pituitary function. This is very important, especially when you deal with the pediatric infra-diaphragmatic craniopharyngioma. So if you follow up this patient over the time, you can at the end say that this tumor for sure have a better prognosis if you compare with the more troublesome supra-diaphragmatic craniopharyngioma. And even if they can regrow, and of course they regrow, you can repeat again the transsphenoidal approach to empty the cystic cavity again. And at the end, this tumor have a really good prognosis. And different is the situation when you deal with the supra-diaphragmatic craniopharyngiomas, because of course the relationship this tumor have with the surrounding neurovascular structure. And the endoscopic endonasal approach have been proposed to treat this tumor, even if since the 80s, even with the microscope, some authors like Martin Weiss, Ed Laws, Kuldwell, and other pioneers have tried to remove this tumor even with the microscopic transsphenoidal approach. But no way to say that it's of course thanks to the endoscope and to the pioneering work made by the Pittsburgh group, mainly by Dr. Kassam and Dr. Karau, that it was possible to standardize this kind of approach for supradiaphragmatic lesion. Of course, in this case, you have to be a little bit more invasive in the nasal cavity because you have to remove some nasal structure like the middle turbinate. Sometimes you have to remove also ethmoid cell, resect part of the nasal septum. You have to raise nasoseptal flap. But this gives you the opportunity to have a wider surgical corridor that allow you to move properly the surgical instrument. This because, as you can see, you have to resect an extra amount of bone above the level of the cella. So in this case, your bone removal is not limited anymore to the cella, like with the approach we saw for infra-diaphragmatic craniopharyngioma, but we have to extend more on the planum sphenidae. And very important, we have to extend our bone resection also laterally over the optic prominence toward the lateral optocarotid recess. If we remove the bone properly over the cella, we can get access to the intradural compartment where we can expose these four areas. We can work above, below the chiasm, in the retrocellular space, and even inside the third ventricular cavity. And this is an example of craniopharyngioma growing in the supra-diaphragmatic space. You see that you can work above the gland, you can dissect the craniopharyngioma from the pituitary stalk, and very important, you can work even behind the cella. In the retrocellular space, you can dissect the tumor capsule from neurovascular structure. And very important for craniopharyngioma is to check where the tumor is attached to the floor of the third ventricle. You look here, for example, this because you have to avoid any traction on neurovascular structure, and you have to respect all the teeny perforating vessel, as we will see. And you can even work above the chiasm. You can recognize the normal ventricular wall. Here are the both foramina or Moro. But anyway, these are really the main benefit of this approach. But the principle of tumor resection, of course, are the same we use for transcranial approach. So never en bloc resection, bimanual blunt and sharp dissection, and very important in all skull-based surgery, but and of course also for craniopharyngioma, is to prefer all the perforating vessel. And you look here, another example made with the 4K camera. The quality of color is not so good, but you see that the resolution of the camera allow you to recognize even this teeny perforating vessel, which absolutely have to be preserved. And with the bimanual technique, you have to dissect and remove. And you see how many perforating vessels you have in the retrocellular space when you expose this area with the endoscope. This is our series. We have treated more than 120 craniopharyngioma, and the vast majority of the patients have been operated with the extended approach. And also a lot of patients were operated for the first time with the endoscope, but we have also patients already operated through other approach. And the good things is that you can use this approach even for pediatric craniopharyngioma. As you know, there is one of the two peaks of incidence of this of the craniopharyngioma is in the pediatric age. So it's important to know that especially during the recent year, there is an increasing number of pediatric craniopharyngioma that are treated with the endoscope. And you can treat either supra-diaphragmatic and infra-diaphragmatic craniopharyngioma. This is an example. Of course, the corridor is a little bit smaller as compared to the adult population, but with the proper instrument and sometimes using a thinner endoscope like the 2.7 millimeter endoscope, you can approach this pediatric supradiaphragmatic craniopharyngioma. You can even preserve sometimes the stalk and some part of the pituitary function. Of course, not all the craniopharyngioma can be managed through the endonasal route. You have to check some things when you plan, especially the chiasm position, the distance of the chiasm with the pituitary surface, the encasement of neurovascular structure. So it's very important when you speak about craniopharyngioma and endonasal route to consider this classification, which has been proposed more than years ago by Dr. Kassam. And it's important because it's related to the position of the pituitary stalk, so that we can classify in pre-infundibular, transinfundibular, and retroinfundibular craniopharyngioma. This is a series we made together with the Bologna group in Italy, and we approached all these kind of craniopharyngioma. And it was clear since the beginning that we have a significant improvement in visual function in this patient. With a good gross total resection, even if at the beginning we paid the price of a higher rate of CSF leak. And another point is that we noticed that we have quite a large number of patients with the tumor growing through the infundibulum inside the third ventricular cavity. And in this subset of patients, the rate of tumor removal was quite good as well. And if you look this picture, you can understand why it's quite easy to enter the third ventricular cavity when you come from the endonasal route. Because when you have a tumor growing in this area through the infundibulum, tumor push down the floor of the third ventricle and create a sort of corridor to enter into the third ventricular chamber. We have studied this region from the endonasal perspective, and we have defined the 4 areas that we can explore: the infundibular, the foraminal area, the mesencephalic area. You see here, you can explore up to the abenular commissure. But it's very important to remember that when you navigate with the endoscope inside the third ventricular cavity, this cavity seems to be quite avascular. But when you look from the outer surface of the ventricular floor, you see how many teeny perforating vessels you have here. So it's very important to never violate the floor of the third ventricle, and it's very important to recognize these prominences along the floor of the third ventricle, which are the prominence of mammillary body. If you damage this structure, you will enter into the mesencephalon. These are an example of some cases of picture with of craniopharyngioma with intraventricular extension, and you see that the structure can be distorted by the tumor, sometimes because of the hydrocephalus, some other time because the pressure of the tumor on the paraventricular space. But again, look always the floor of the third ventricle, how it appears. This is a normal floor. You see prominence of mammillary body. This is a short floor. This is a long floor. And look here, the floor was interrupted by the tumor, and here you can recognize posterior cerebral artery with some calcification attached. And here are the prominence of mammillary body. So you have to be very cautious when you remove the tumor in this area. This is an example in another video. You see, after the removal of the solid part of the tumor, we start the peeling of the capsule of the tumor from the ventricular wall. We usually start from the upper part, which is the more safe area. Then we dissect the capsule from the ventricular wall. And this is possible when there is not PL invasion. And then at the end, and only at the end, we resect the part of the tumor along the floor of the ventricle. And here you can recognize the prominence of mammillary body, and that's the post-op MRI. This is a collection of cases we have treated with the intraventricular extension. pre and post-op MRI. And you can treat also some cystic supra-diaphragmatic craniopharyngioma. Cystic lesions are never easy, and this is true also for craniopharyngioma. You have to be very careful when you remove this cystic tumor. And you see, this was a pediatric craniopharyngioma. You see pre and post-op MRI with gross total removal. But sometimes when the capsule is truly adherent to the neurovascular structure, it's very important to fenestrate this cyst cavity with the basal cyst. Otherwise, the cyst will come back soon again. So multiple fenestration, and if you have some remnant on cyst wall, you have to do radiotherapy on the cyst wall as soon as possible, because radiotherapy is quite effective on cyst wall, so that on long-term follow-up you can see it was quite disappeared in this case. But you can use this approach, of course, for recurrent craniopharyngioma. This patient had already 2 transcranial surgery, plus Ommaya reservoir implant, plus radiotherapy, and the tumor came back again. And so you can change the route. So instead of doing a gate transcranially, you can do endonasally, because you can use a virgin route and avoid all the scar you had due to the previous surgery. But sometimes you can have the opposite situation, like in this case. So, for example, this patient has a previous transcranial surgery plus radiotherapy. This patient has previous endoscopic endonasal approach. In this case, we use a transventricular approach. You can put catheter inside the cyst, and you can connect to a Ommaya reservoir, or you can have another situation, patient which have been already operated transsphenoidally or even transventricular, like in this case, or this is another case who had an extended endonasal approach, and then the patient recur, and these cases have been operated transcranially. So not a single surgical option is enough to manage this kind of lesion, but you need to have all the spectrum of surgical possibility to manage this kind of tumor. But of course, surgery is not the only answer for the cure of this disease. We are trying to understand why some craniopharyngioma recur more frequently than other. This is one point. And we have also to consider that we are starting to have some drugs to treat some subset of craniopharyngioma. I mean, those who have BRAF mutation, and and maybe in the future we will also have the possibility to understand if this BRAF mutation is present also using radiomics. So on pre-op MRI, maybe in the future we will be able also to know if there is this mutation, so that we can plan properly our surgical strategy. This is for craniopharyngioma, and then I will move in the second part of the presentation, speaking about pituitary adenomas. As was pointed out several years ago by Dr. Laws, the indication for transphenoidal approach for pituitary adenoma is absolutely correct, and it is made in more than 97% of cases of pituitary adenoma. So since the beginning was clear that this route, the transphenoidal route, was effective for the treatment of pituitary adenoma. And we have used over the years all the variation of the approach, up to, of course, the endoscopic endonasal route. The original idea was of this Korean neurosurgeon He Dong-jo, who proposed it for the first time in Europe in 1996, and his experience was then followed by our group in Naples and by other groups in Italy. And if you look this picture, you can realize what was our setup in the OR at the beginning of our experience. We used the CR fluoroscopy. The equipment was just adapted for this kind of approach because we had no instrument specifically designed for this procedure. And you look, we mix some equipment from other approach from ventricular surgery. And the first endoscope we used for the pituitary surgery was provided by urologists. And it was 30 centimeters in length, just to give you the idea. But then the equipment became much better. You see, we entered into the digital era, and until 2004 we use holder, endoscope holder, to allow bimanual working. But of course, the big improvement we had switching from the mono CCD camera to the 3 CCD camera, from the halogen light source to the xenon light source. And you can compare the two pictures and understand how much was relevant the improvement in the picture. But technology is moving on. We have also checked and tested the 3D endoscope in the OR. You see here Dr. Solari working with the 3D endoscope. We have used also OLED screen visor, and you see here these are quite good for the people who are watching the procedure in the OR, but not for the surgeon. And of course, we have used also Ultra HD camera. Not too much to say about standard pituitary surgery because as you can see in this picture, the main benefit provided by the endoscope is given by the fact that you can switch from a panoramic view inside the sphenoid sinus to a close-up view inside the cella. And this is something that it was not possible to do with the microscope before. So the principle of a standard endoscopic approach remained the same. Also the same are the indication for functioning pituitary adenoma. But what we can do with the endoscope? Again, we can remove what we defined as a conventional pituitary adenoma. These are the conventional, these are the daily case of pituitary adenoma, from a small intracellular to quite large, but with a symmetrical supracellular extension. And these you see also on sagittal projection. These tumor can be removed, of course, even with the microsurgical transsphenoidal approach. But then with the endoscope, we moved around the cell so that it was possible to approach also the cavernous sinus through the medial or more rarely through the lateral corridor. And you see an example on how you can enter the medial wall of the cavernous sinus passing through the cell. It's quite easy. You have just to remove the tumor and debarking the part of the tumor inside the cell. With a curved suction cannula, you can enter through some dural pocket in the medial wall of the cavernous sinus, and with the suction, you can debark the tumor inside. More rarely, honestly, more rarely, you can work laterally to the carotid artery. You can enter these corridors, which are more frequently used for trigeminal schwannoma. But again, there are some pituitary tumors which grow in the lateral recess of the sphenoid sinus, so that following the tumor, you can expose the lateral recess and you can resect some part of the tumor extended even lateral to the carotid artery. But with the endoscope, you can do more, so that you can treat even what we define as the unconventional pituitary adenomas. And these unconventional pituitary adenomas are those tumors that maybe in the past we preferred to approach transcranially. Why? Because they have a more irregular shape, they have some encasement of neurovascular structure, they have a dumbbell-shaped configuration. Sometimes there are recurrent pituitary adenoma. Some other cases are growing over the tuberculum or are entering the third ventricular chamber. So these tumors are absolutely not daily case. They deserve a different strategy. So these are what we define as unconventional pituitary adenoma: dumbbell-shaped, pericellular extension, encasement of a neurovascular structure. In this case, there is quite often violation of the subarachnoid space, and sometimes there is intraventricular extension. So that you have to realize the same approach we saw before for craniopharyngioma. You have to extend your bone resection above the cell, and this is the kind of tumor you can approach with extended approach. You see, we start like a normal pituitary adenoma, but you soon realize that you have a descent of the cistern with a lot of tumor still intracranial. So you don't have to leave that tumor intracranially, otherwise you will have infarction of the tumor, but you have to work above the diaphragm. You have to dissect the tumor from the neurovascular structure. And pituitary adenoma are even more challenging than some craniopharyngioma, because the surgical field is more bleeding, because the capsule of the pituitary adenoma bleeds more. So you have to resect and identify all the piece of capsule. And at the end, you see here the stalk with the residual gland, the chiasma, and then the reconstruction. We will see later how we close it. Oh, sorry, there was the post-op. Yes, this is the reconstruction and the post-op MRI with just a small residual tumor above the supraclinoid portion of carotid artery. This is another case with the tumor extension inside the third ventricular chamber. Again, you start with the resection of the cellular part, then you coagulate the diaphragm and go above the diaphragma cell. It's very nice that you can use double corridor. You can debark the tumor from inside the capsule, and then you can dissect the tumor from the outside. You see very strange way to grow for this tumor in between the ACOM and the chiasm through the lamina terminalis. You see, we are resecting now this piece of capsule, which will allow us to enter the third ventricular chamber. You see here. And at the end, the panoramic view, you see the corridor we used to enter. This is the lamina terminalis that was open to enter the third ventricular cavity. The diaphragm that was coagulated, and the post-op MRI. But how frequently we use this extended approach for pituitary adenoma? Very rarely. So the vast majority, 95% of pituitary adenoma are removed through a conventional transsphenoidal approach. Okay, so no need to do any extended approach for pituitary adenoma. But just for this limited number of cases that in the past was the same number of cases we approached transcranially, that we use extended approach. Okay, and it's interesting to know that we have a lot of these unconventional pituitary adenoma comes from recurrences. So sometimes when you have a recurrent pituitary adenoma, it's not an easy case. Okay, and also the rate of tumor removal, as you can see, is lower if we compare to the rate of gross total resection we have for standard pituitary adenoma. And also the complication rate is higher. You see more CSF leak, more vasospasm, more visual working. Of course, it's not high if we compare to the complication we have when we use a transcranial approach for pituitary adenoma. Okay. And I just want to show you one example of complication. You see, this was a recurrent pituitary adenoma. The resection was quite good, but this patient has some vasospasm, and you have to check and to study this patient very soon. When you operate this patient and you see in the day after or some hour after the procedure, some behavior change in the patient, you have to check with the angiography. If there is some vasospasm, you have to do infusion of the nimodipine. And if you do this very soon, and in case you repeat even this procedure, you can have a good outcome, like in this case, with just a limited ischemia. Another point is that when you deal with this tumor, you need a dedicated instrument, you need a dedicated set for extended approach, because you need the longer instrument, especially when you have to enter the third ventricular chamber, you need longer instruments. And also on pituitary, we are trying to understand some more information, especially on the consistency or on the proliferative index of pituitary adenoma using radiomics. And last few slides are on reconstruction, because reconstruction was considered really the Achilles heel of of this procedure, and we have used a lot of techniques over the last 20 years to try to seal the defect. And this is the last evolution, is 3F. It's a quite easy technique. It's made just by fat, flap, and flash mobilization of the patient. Fat used as a cork stopper, not inside, not outside, but across the skull base defect. This allows us to avoid multi-layer, gasket seal, sphenoid sinus balloon, and nivel lumbar drainage, which are not used anymore. And then the nasoseptal flap, which is used to cover the skull base defect, and then flash mobilization of the patient, which has never has to be supine in the bed, but has to stay in a semi-sitting position, and you have to mobilize the patient from the bed as soon as possible. This is the last video and the last picture, just to show you that even when you have a very big tumor like that, the cavity with the fat, you don't have to be feared of the use of fat, because if you have the transmitted pulsation of the brain through the skull base defect, that means that you are not overpacking. And also, if you don't use a rigid closure, the risk of overpacking is really eliminated at all. You see that we pack completely the surgical cavity with the fat, then we use just a thin layer of fibrin glue, just a thin layer, not too much. And then we cover the entire defect with the nasoseptal flap. We pack the sphenoid sinus with some surgicel, and this is the early post-op MRI. And you see after 1 year how much fat has been resorbed. I think this is my last slide, and with this I finished, and I really would like to thank you for your attention.
Thank you, Professor Cavallo. It was a wonderful exposition of your technique for the craniopharyngiomas and pituitary adenomas. And basically, you have shown that what endoscopy can actually achieve uh, and why the number of transcranial procedures are coming down as time passes. I think many of these unconventional cases would probably uh, needed transcranial approaches. Uh, there are some questions from audiences, but before that, I would like to uh, say a few things. One of the very interesting things which you spoke about today, and I have not heard before, but have somewhat similar experience, is the consistency of the craniopharyngiomas, which are purely infra-diaphragmatic. They appear so much like pituitary tumors that sometimes it is very, very difficult to uh, actually make the difference till you realize that there is a pituitary behind this, and you can many a times able to separate the pituitary if you are careful from the tumor itself. And sometimes you can get it even below the pituitary, and you might find stalk and pituitary right at the top of your procedure. So that was a very nice experience, which uh, uh, I was very happy to see. The second thing you mentioned about is the landmark of the mammillary body while going near the floor of the third ventricle. I think it's a very, very good point which has not been emphasized enough. Before you uh, differentiate between the ventricular floor and go retrocellular, because all the tumors which have gone retrocellular have Liliequist membrane is breached. So you really have no good landmark there, and therefore it is very important to keep on looking at that. One of the things which Amin Kasam has emphasized in terms of the relation of the lesion with the pituitary stalk, I think there is some confusion in people's mind as to the pre-infundibular, infundibular, and retroinfundibular. You can actually get a retrochiasmal tumor which can still be pre-infundibular. And therefore, the corridors which you showed for a um, uh, supra-diaphragmatic tumor, but still most of them are infrachiasmal, and many of them are anterior to the stalk. I think that is very important to understand. So you may have a tumor which is sort of gone posterior to the lamina terminalis, but uh, you still have the pituitary stalk just at the back margin of your tumor, and therefore you can safely remove that tumor. One of the interesting things, and I would like your comment on that, is for you to go into the supra-diaphragmatic corridor from there. In one case, you showed that you can go above the diaphragm when you do a uh, extended approach, because you can literally go to the anterior margin of the diaphragm and try to look up. But you also showed that sometimes you can go suprachiasmal even from behind. That is something I am a little curious to know, how do you achieve that and how can it be safely done without damaging any perforators. Uh, I think overall you have shown a very nice technique. The only thing I can add, which we recently published, as you might know, is when you are dissecting the capsule of the dome of the tumor from the side walls of the uh, third ventricle, inside of the third ventricle, we found that it is much easier to do that if we have drained the cyst earlier. So many tumors which are having intraventricular extension, we do a transcranial, I mean through a burr hole, we put in an endoscope, drain the cyst, and within a week we operate, so that when we are removing the tumor from the transsphenoidal approach, we find that it is much easier to dissect the tumor out from third ventricle. And many a times when you start debulking, the dome just falls down nicely and you do not have to dissect very much in that area. So I think I would like you to explain me a little bit about the use of supradiaphragmatic corridor before I get the audience questions, and then I can move over to Raja.
Thank you, Professor Dorbujari, for your comment. The cases in which I showed that we worked above the chiasm is just because the position of the chiasm is not common to work above the chiasm.
Okay, great.
Usually this route is used to work below and behind the chiasm, but sometimes the configuration of the tumor rotate the chiasm anteriorly so that you can, it gives you the possibility to slide with instrument even above the surface of the chiasm to enter through the lamina terminalis. But this is not frequent. It doesn't happen frequent. This is one point. And the second, of course, you have to deal, you usually deal with giant tumor. I can only imagine, but I saw several times your cases, and quite often they are giant cases, and you are absolutely right. It's much better if you deflate the cyst from above and then you resect from below. So this is absolutely one of the possibility, and I have nothing to say against this technique, which is absolutely useful. So thank you again for your comment.
Thanks. The one other thing I can probably add, we have probably a little more experience in children, and I can say a few things. I think one important thing to understand is that uh, over the age of 4 years, it is usually possible because the intercarotid distance is not really very small. So you need not worry if the child seems to have a reasonable nares where you can, insert an endoscope easily. It should be possible for you to operate. The other important thing to understand is that the sphenoid sinus is also not very difficult, and if you have a good navigation, you can literally go through a sphenoid sinus even if it is not fully aerated. So I think it is safe to operate in children, and you can do it, but do it after seeing the external nares if you can safely put your scope. And secondly, make sure you have navigation at your hand if you have any problem with the anatomy of the paranasal sinuses. Over to you, Dr. Raja.
Well, thank you, Professor Cavallo and Professor Pujari for such excellent comments. We are so fortunate to have two giants of neuroendoscopy and to hear such pearls of wisdom from you both. We are really fortunate today. Now we shall open this platform for discussion. There are many questions which have been popped up, so I'll just call one by one. There is Professor Shijoy Joshua. Would you like to ask your questions?
Good evening. That was a beautiful talk. My one query, during your talk, you just said that you would be irradiating the residual tumor early and not on follow-up. How early do you irradiate the residual capsule?
When there is a visible residual tumor, we usually irradiate it with the gamma knife, usually, or with the fractionated, but we usually irradiate remnant.
Yeah, in how much duration do you wait for the residual, do a 3-month MRI and later on?
After 3 months. We repeat MRI after 3 months, and if there is a remnant, we send the patient to the radiotherapy treatment.
Okay, thank you.
Yes, Harshal.
Yeah, hi. It was a wonderful lecture, Professor, and great comments from Dr. Pujari. I just wanted to know, in recurrent cases, how do you go about your closure where nasal septal flap would have been already used by the surgeon in the first surgery, or this patient would have been radiated later on?
This is a problem. We try to avoid to reoperate through the same route 2 times because we have less material. But in case it is possible to reduce surgery through the endonasal route, we simply detach the nasal septal flap, remove the the fat or the reconstruction material, and then we plug again a new piece of fat, and we reposition the nasoseptal flap. But otherwise, we try to use another surgical route for recurrences.
Harshal, I am myself surprised that you can uh, sometimes, I mean, if you are able to literally peel off the flap in some cases, especially non-radiated cases. I think in radiated cases, you certainly need to think of another solution before you do that. One more thing I should add, Professor Cavallo, you showed beautifully with the cork how you actually put the fat and what is the philosophy behind putting a plug of fat. What we try to call it, we call it a bath plug. So we actually put a stitch onto the fat, and we put the fat inside, and we then pull it out with the stitch so that it gets stuck in that hole in a good way, and then gently spray the glue. So we therefore call it a bath plug with a string.
That's
So
nice.
it's a similar technique, but a little different way of introducing it.
Well, we have used the fat, of course, even for pituitary, but the great advantage we noticed in extended approach is to encase the piece of fat across the skull base defect, because we noticed that most of the leakage comes from the border around the optocarotid recess in that area, because that corner are quite difficult to seal. So the idea was to put really a sort of cork stopper, which can be easily give us a sort of watertight closure along all the border. For us, it was the most fast and easy way to seal the entire skull base defect, avoiding multi-layer reconstruction. And another point, when you use multi-layer reconstruction with the dural substitute, in case you have a recurrences, it's horrible to remove this layer of dura. It's absolutely horrible. Sometimes it requires more time to remove the reconstruction than to remove the tumor. And you need to use Doppler to check carotid because you have distortion of neurovascular structure when you have uncovered carotid artery. So it's absolutely horrible to remove multi-layer reconstruction. And especially, as Professor De Puciari said, if this patient have been irradiated, it's even more difficult because everything is attached. So in this case, maybe sometimes it's much better to go transcranially or transventricular or to find other solutions.
Right.
I would just like to ask you and make a comment on the closure technique once again. See, you have published the various grades of CSF leak, and what we are really dealing with is the highest grade of CSF leak when you undertake a surgery like extended endonasal approach, and the defect caused is also fairly big. So why is the reluctance to put a lumbar drain? Because we always advise lumbar drain in patients where you open the ventricle or where you have a large defect for the first 24 to 48 hours at least. Why have you gone away from that? That
Because,
was one question. And just an addition to next that
we have
is,
used it.
yeah.
We have used the lumbar drainage a lot. We have used it like a routine case, but in our experience, it failed, and it prolonged the bed stay of the patient. So we used the lumbar drainage, and we had the CSF leak as well, even in high-risk cases. So what we noticed that is much more effective if you allow the patient to leave the bed and start to work as soon as possible, instead to having the lumbar drainage for 1 or 2 days, because when you remove the drainage, you again start to have a high pressure of the CSF leak. So this is the reason why we never leave the patient supine in the bed. But even if you have pneumocephalus after surgery, we put the patient in semi-sitting position because these decrease the pressure intracranially. And it's quite easy to have a proof of this when you, during surgery, if you are operating with the patient supine and at the end of surgery, you put a piece of fat through the skull base defect, and then you elevate the trunk of the patient, you will see that the negative pressure will move the piece of fat intracranially. This means that at the level of the skull base defect, when you have a semi-sitting position, you have a negative pressure. And if you leave this negative pressure during the entire post-op stay, probably the lower pressure on the skull base defect will help you in the healing of the skull base reconstruction. This is the reason why at the end we are not using any more lumbar drainage. But of course, never say never, because in some high-risk cases, like extremely obese patient who have been already irradiated, or patient with a wide opening inside the ventricle, for these selected cases, we use lumbar drainage. So never say never. There are cases in which we still consider this possibility.
Thanks for your detailed reply, because I was wondering that even with the opening up of the third ventricle, do you still mobilize the patient? That was the question.
Yes.
Okay, great.
The day after, anyway, within 48 hours. It depends on the degree of pneumoencephalus. And it's important to wash a lot with the ringer at the end of the procedure. Try to filling as much as possible the ventricular cavity before you close.
We'll take few comments from Professor Yadav, sir. Dr. Yadav?
Sure.
Yeah, this was excellent. Yeah, excellent talk. I enjoyed, and almost everything has been covered very well. And the comments, I enjoyed it. Thank you very much. Nothing to add.
Professor Muthukumar?
Just a small question regarding closure to Dr. Cavallo. Generally, I have heard most pituitary surgeons, they prefer to apply the glue after the application of the nasal flap, because generally it's said that if you apply a fibrin glue over the fat and then apply the flap, it interferes with the fibrosis. But I saw you doing the other way, fat, glue, and then flap. Is there any specific reason for doing that? Because most pituitary surgeons do it the other way around. They apply at least if I have understood correctly, they apply it at the end.
You are right. I said just a thin layer of fibrin glue, just a thin layer to support the fat. Not too much, because you are absolutely right. Fibrin glue interferes with the healing with the attachment of the flap over the fat. So just a thin layer of fibrin glue to leave the fat in the correct position during the reconstruction. This is the reason.
Yeah, my co-host, Dr. Liu.
Yeah, hello, Prof. Thanks for very interesting and many good surgical technique and example. I just wanted to ask a few questions, Prof. Have you come across pure third ventricular craniopharyngioma? And can we actually approach same from a transfemoral approach, since you have shown us that you can actually open the lamina terminalis from below? And is it a possible technique for pure third ventricular craniopharyngioma?
For purely intraventricular craniopharyngioma, just when you have selected the condition, we have two cases of purely intraventricular craniopharyngioma, but we have removed through the tuber cinereum, not through the lamina terminalis from below. From the tuber cinereum, because the floor of the third ventricle was a little bit pushed downward. And in both cases, the patient had empty cella. So we have a larger corridor, natural larger corridor. But otherwise, you have to use a conventional transcranial approach to remove this tumor.
Yeah. My second question, Prof. I heard there are some other presenters talk about type of fat that you use. sometimes those who harvest fascia lata, they will take that kind of fat as a so-called flat fat. And then the one we harvested from the abdomen is different type of fat. So what's your opinion regarding, is there make any difference in as our fat replacement?
Dr. Stam, who use fascia instead of fat, and he called it the 3F. Yes, I know this. We didn't know each other. But I don't like fascia. I mean, you can use fascia when you don't have any more nasoseptal flap, when you don't have turbinate. But otherwise, I don't like to harvest fascia lata from the patient, because sometimes they complain pain for months, you have an additional scar. And when you use fascia, it's always not easy to remove in case you have to redo surgery. So for us, it seems much easier to just put a piece of fat and cover it with the nasoseptal flap. But we have used it in the past. Fascia. We have tried in the last 20 years, I think we had used all the possible technique that have been described during a meeting on literature. We have tried everything because the rate was really high. The rate of post-op CSF leak was really high with this technique, with the previous technique. Now seems to be much better, Not solved completely, of course, not solved, but it's not solved completely even for skull-base surgery in general. You know, the more you stay close to skull base, the more increase the rate of CSF leak. So we have some way to live with a certain rate of post-op CSF leak. We have to consider this.
Yeah. Prof, want to ask you during the flap that we produce, the Haddad flap, I have came across that when doing harvesting, we actually injured the pedicle. So it's become a non-vascularized flap. In Prof opinion, can still the flap be used as good as the pedicle flap, or we should harvest the other flap?
Yes, even if you have a free flap, is okay. It's okay. I think it's more important what you do at the level of the skull base with the fat than what you cover with the nasoseptal flap. If the fat works, the flap will work as well.
Okay.
They're more important.
My second last question, Prof. In a large functional tumor with a neurological deficit with bitemporal hemianopia, functional tumor, functional macro adenoma, functional tumor, how long do you wait for the medical therapy to work before you decided to go in to decompress the optic apparatus?
This is a discussion we do together with the endocrinologists. I mean, usually this happens for prolactinoma, for example, and it's almost everywhere accepted that if you have a moderate compression on the chiasm and you have elevated prolactinemia, you can use dopamine agonist, and you can wait 2 weeks, repeat visual field test. If there is an improvement and on MRI shrinkage, you can wait. Of course, if you, after 2-3 weeks, you have no improvement in visual function and you still have compression on the visual pathway, you have to reconsider this case for surgery.
My last question, Prof. In the cases that you have a CSF leak post-operatively, how early do you go in, and do you replace whatever fat that you have put in with a new
two way to manage CSF leak. If there is a minor CSF leak, we go with the endoscopic tower in the ward, close to the patient, and we inject some fibrin glue inside the sphenoid sinus with the patient awake. It's something that the patient usually tolerate. You can repeat this 2-3 times in one day. Just a single injection is not enough, but you have to inject 2-3 times in few hours, and that's all. And usually it works for very minor CSF leak. If there is a large CSF leak and the patient is symptomatic, you have to bring the patient in the ward and to plug in again the fat and try to understand why there was the leakage.
Can I interfere, please?
Yeah, please.
Professor Cavallo, I mean, I really attended a very, very nice lecture now, and in your center, you are doing very, very, very fine things. The only thing that I wanted really you to elaborate more is in your extended approaches, I mean, anteriorly or posteriorly, or when you go laterals, what are the main tricks or tips that you are advising us to avoid the complications in such regions? I mean, mainly in the cavernous sinus, and even you are going lateral to the carotids. I mean, there are possibilities of the injury of the cranial nerves or the carotid itself. And anterior or posterior, when you go and find the traversing sinuses, what are the tricks that you are using to avoid bleeding or disconnection from these sinuses? Thank you.
This happens quite frequently, especially with the craniopharyngioma, the bleeding of intercavernous sinus. And what we do usually is to isolate the superior intercavernous sinus. We do 2 parallel incisions of the dura above and below the sinus. We isolate the sinus, and then we coagulate with bipolar, and then we cut. But sometimes when you open the bone with Carrison, you make injury on the sinus, and the best way to stop the bleeding is to use Flow-Seal. Flow-Seal is marvelous, is an hemostatic agent. I think is the new bipolar we have, the new way to do hemostasis, and on venous bleeding is absolutely effective. It's called the Flow-Seal or Surgiflow, or but it's thrombin. So when you have bleeding for venous bleeding during the approach, the best way is to inject Flow-Seal, to put a cottonoid over and wait for 1 minute. This is the way. And honestly, I have to say that in extended approach, in every surgery, we use at least 1 or 2 bags of Flow-Seal, because this is a bleeding procedure, at least in the nasal step. And another point is to do a wider corridor. Never do small corridor for large surgery. So you have to resect 1 turbinate, you have to resect the nasal septum. This is the advice I can give you.
What about avoiding the injuries to the carotid? Or if you have an injury to the carotid, what you will do?
We had injury of the carotid for pituitary surgery. We had in our series 2 carotid injury, but it happened in the extra arachnoidal space, you know, because there was an injury of intracavernous carotid artery, and we used over the time 2 strategy. One case we made packing, then we went in an we had a sort of pseudoaneurysm that was embolized. In another case, we made angiography. We checked with the occlusion test the perfusion from the opposite side. It was good. The patient was young, and we embolized the carotid artery. Usually, if you do a small tear, a small injury on carotid artery, and you pack with muscle, and then you pack with cottonoid the entire sphenoid sinus, you have time to refer the patient to angiography, to endovascular procedure. But of course, this is an unpredictable event, so you never know. There are reported cases of death on the surgical table because the bleeding was not controlled. And usually, and luckily, this is a limited experience for each of us. I mean, each of us has an experience on 1, 2, 3 carotid artery injury, which is something that you will never forget, but it's of course good to have endovascular service. It's good to have endovascular service.
What about the cranial nerves in the cavernous sinuses?
But for pituitary, usually it's not a big issue, because pituitary are soft tumor, and you remove what is possible to remove. And I would not be aggressive for pituitary tumor in cavernous sinus. In fact, I say that only rarely we went lateral to the carotid for pituitary adenomas. Usually we debark the cavernous sinus through the medial wall, and pituitary adenoma usually are soft. So you remove what is possible, and then you follow up the patient for the remnant, and in case of growth, you can irradiate. But usually you don't need to be aggressive on pituitary adenoma, absolutely.
I think that was an extensive discussion. I think we would wind up this session of webinars. Professor Dev Pujari, any final comments?
I think it has been an excellent session and quite a few things, messages to take from here. Thanks.
Thank you. So then I think we'll close this session. On behalf of the ACNS Education Committee and the President, Professor Yoko Kato, I would like to thank Professor Luigi Maria Cavallo for coming here and sharing his wide knowledge about neuroendoscopy in pituitary and craniopharyngiomas, and also Professor Dev Pujari for coming here and sharing his time, his expert comments. We had a lot of learning today. Thank you all the attendees who came here. Thank you, Liu, for joining us. Until next Saturday, it is bye-bye from all of us. Thank you, Professor Cavallo. Thank you, Professor Dev Pujari. Thank you, everybody. Until then, bye-bye from all of us.